lovely introduction, Joan. Good morning, everybody. It is a huge pleasure and pride to be here today because I'll tell you a little bit about that in a minute. But I think looking at this conference, looking back at that theme of looking back, moving forwards, it is, I think, at a very interesting point in our lives. What challenging decisions do we face at the end of life for end-of-life care? What do we mean by that? How should we face this? What tools do we have? What do we use? So I'm going to kind of take you through. Some of this is slightly clinical, some of this is actually more around system and leadership and so on. So we'll kind of do a little bit of a mishmash moving around. But if I look back, first of all, it is a huge pleasure to be back. And my claim to fame, which I still use, is that I was the very first SHO in this country in palliative care. But the other claim to fame, of course, is that for me, it's also because it was because of that first SHO job that I have the career that I have in palliative medicine. Because when I came here, I was a GP trainee, all set to finish my GP training, which I did in Trim County Meath, but I did that only because the then medical director, first doc, old doc, and then my county would not let me give up my GP training to stay on here. They insisted that I actually finish my training, which I did, and I was very grateful for. And then at that point, I was inveigled to go out to Hong Kong to work in palliative care. So this place has had a massive impact on my life ever since. But when I look at the years, I realize that this is a 25th conference. This conference didn't exist when I was here, which means that I was here longer than that. It was 30 years ago. 1989, I was here for 3 months. That's all, but those 3 months made a huge impact. In fact, I actually went on and did on call here for about another 6 months after that, because they were still setting things up then. So, but actually my relationship with Our Lady's Hospice goes back even a little bit further than that, because in those days we didn't have palliative medicine training as medical students. And my very first contact, my very first idea even about this whole area of care came from a panorama program when I was a fourth med, and I asked if I could come and visit, and I spent Christmas Day that year here, and that was a really, really influential piece on me, I think. So if we then look at what in England would be considered sort of Dame Cecily Saunders, it was the start of the hospice movement, but of course I've always known because of my training here that Our Lady's Hospice was even before that, way before that. So in terms of roots, I think that is kind of the looking back that we've got. But if we think back of those times, that was about holistic care. That still is about holistic care. We talk about symptom management being important. Those were the challenging decisions at that time, is how do you best support somebody who is dying? How do you improve symptom management? How do you get better education? How do you get to reach more people through that education? How do you do research in this area? And in those days, you were concentrating much more on people with cancer and people with neurological conditions. But the dream that Cecily had was always that it would actually eventually become mainstream, and then we wouldn't need the specialty. Well, at that time, it wasn't really a specialty, but you wouldn't actually need hospice care. Well, you and I know here that we're needed ever more. So that's the kind of, if you like, challenges in the past that you think you had, but actually you have to move on from those challenges. Well, what about today? Well, today we had all of the above, but I think we've also got some really interesting challenges for ourselves. We know that cancer has become more chronic. So therefore, the very simple trajectory that we used to have where you went down like that and then you went like that is no longer true. We know that there is a lot more people with non-cancer conditions and with multiple conditions who need our care and support. How do we manage that? We know that there is much more diversification within the specialty of palliative care. There is beginning to be murmurings of people who are doing much more symptomatology, people who are doing much more right at the end of life, people who are only in hospital, people who are only in hospices. There is much more diversification. My personal view is we are too small a specialty to be trying to diversify to that extent, that we should be able to continue keeping our skills right across that board. But maybe you'll challenge me on that later on. I think also that blurring between what's generalist, what's specialist is becoming, certainly in England, quite a subject of debate. So on the one hand, we are saying that actually palliative care, end-of-life care is everybody's business. But if it's everybody's business, whose business it is to drive it forward, to look at the research, to push forward the boundaries of the knowledge and the understanding. So I think that's the kind of debate that we currently have. And then in the last three I've put up, because they are particular challenges that I face in England, and you may well face too, but I wouldn't want to presume. There has been a rather what I would call unhealthy focus and obsession with place of death, almost as though there is only one place where good palliative care can take place. And in England, that is at home. That is this vision that everybody can have a lovely, beautiful, dignified, peaceful death at home. And of course, those of you who are in practice with, like me, will know that that is not always the case, that actually if we stick to that, we condemn some people to actually a very frightening, scary, lonely death, especially if they don't have family who feel able to support that. There's also a very strong focus on measurement and much more about accountability and being more legal conscious. That is not confined to palliative care, of course, that is right across the board. And Don Berwick, can I just have a show of hands how many people have heard of Don Berwick from the Institute of Health Improvement? Okay, so a few of you have, but he's a pediatrician originally who's kind of gone really big into health improvement. And I heard him speak recently about what he called the eras. So in the past, what he called era one was the era of professionalism. Now, he was talking from a medical perspective, but I think this applies right across the board to all professions. He was talking about the roots of medical profession being about being beneficent and being self-regulating and being able to drive our own standards and be responsible for ourselves. But that this is now the era we're in, the era two, as he calls it, which is the era of accountability. So the first one was we drove it from inside. Now we're being driven from outside. The I'm going to hold your feet to fire kind of a thing. And I get that a lot in my NHS England work where the word deliverable is used. You know, how are we going to account for deliverability and things like that? And measurement and rewards and punishment. And it's not, I'm not saying that some of that discipline isn't important, but of course, if you drive it from outside, you drive certain behaviors. And those behaviors aren't always in the best interest of the people we're trying to serve. So I think there are lots of challenges that we face in actually how do we manage all of those expectations. And those expectations are part of modern society. So it's no good us simply, you know, hunkering down and saying, this is the way we do it, we're special. We can't be. We've got to be able to work with that. So now what about the future? Well, I think, this is pure guess, of course, but I think the future is going to be even more data-driven. The challenge there, of course, is that we need to measure and we need to capture data for what matters rather than simply what we can capture. And that, I think, is where we're at the moment a little bit, is that we're measuring things we can measure rather than measuring things that are meaningful. We are going to be more digital and technology-driven. That's going to be for the good, and there will be dangers in there. And again, the wisdom to be able to manage that, I think, is going to be important. And part of the wisdom, and I am not referring to myself at all here now, because I am not particularly digital savvy, but I think part of the wisdom is recognizing that we're going to have to learn to be digital savvy in order to be able to manage this from within. The challenge of more numbers, we know about that, that is global. More older people, but also more younger people, because of course a lot of younger people are now surviving into much older stages. One of the jobs I did after I left here was SHO to the cystic fibrosis team. And of course in those days, the teenagers, we got them into the adult services, but just about, and they died usually before they were sort of 18, 19, 20 at that stage. They're living much longer now. So we'll have more younger people and we'll have more older people. And we'll have more comorbidity. And then there is a pressure on specialist palliative care to take over in some areas, to take over earlier, to take over later. And certainly in England, and I'll talk later on about the Liverpool care pathway, as a result of that, there's been a loss of confidence in looking after dying people without specialist palliative care teams to hold your hands. So how do you manage that? And I think that there is also a challenge that's now and in the future about growing inequalities. And the more we drive the standards forward, the more we have to look back and make sure we haven't left people behind. And by that, I'm talking about, for example, people who are homeless, people who live alone, people who don't have the family members to shout on their behalf. All of those things are things we have to watch out for. So I'm now going to kind of move on a little bit from sort of that picture and think about, well, what do we do? I'm going to use the word system quite a lot. When I use the word system, I mean not just the clinician with the patient, but I'm actually thinking of how does this, so you can think here, you can think in terms of health boards, but it's more than health boards. It's health boards, society, the wider providers, so that whole kind of area around the person. The word challenging in itself was interesting. I sat back and I thought, what do I mean by challenging? Well, on a good day, challenging to me is exciting. It's full of opportunities. It's a great word. On a bad day, it feels like a mountain that's just too big to climb. It just feels impossible. And it feels like really what I'm saying is challenging is a problem that I can't solve. So depending on how you're feeling, there are days when you might feel differently about challenging. But some of the external challenges are interesting. How do you achieve high standard care when everything around you is volatile, is uncertain, is complex, and it is ambiguous? You get no clarity anywhere. Everything is unclear. So this VUCA, which is a phrase that's used quite a lot, it comes from the business world, really. But it is a sort of environment that I kind of feel we live in quite a lot, and certainly in my role at NHS England, I feel like I live in constantly. I've been doing that role for 6 years now, and I feel like I've been living in VUCA for 6 years, still am. But how do you standardize, personalize care when everything is about individualizing? So how do you get that absolutely gold-plated care for one person and yet manage to standardize that for everybody without giving them just a standard template? So those, I think, are very real challenges. We do this all the time. We've always done this, but we don't often stop to think about it. And I guess today is an opportunity to stop and think about it. But of course, this concept of VUCA also exists at the individual level. And if you think of this lady, Mrs. Doyle. Mrs. Doyle is 75. She's actually a Scottish lady. She got married and came to live in Dublin many years ago. She looks cheerful and smiling, doesn't she? I think it's a lovely picture of her. But she is sick to death with worry. And she's sick to death with worry because she has a husband who's older than her, who has dementia. Her daughter, Anne, was the co-carer. She's only got one daughter. Anne was the co-carer, and Anne has just been diagnosed with metastatic pancreatic cancer. They have no other family locally. Anne was the one who's the breadwinner. She was the one who pays the rent on the house they live in. So suddenly, Mrs. Doyle is in this situation where actually everything has suddenly become uncertain and everything has become just so volatile for her. And she's overwhelmed with information because people are giving her lots of leaflets about pancreatic cancer and they're giving her leaflets about dementia, but not enough information that's specific to them and specific to their situation. And things are happening too fast and too slow at the same time. You know what I mean, don't you? You have plenty of patients who are in that situation. And plenty of times when you feel you're in that situation too. So I'd like you to hold Mrs. Doyle in your head, because I think when we talk about systems, when we talk about leadership, when we talk about what we try to do at a kind of strategic level, it only matters if we change things for the person right in the middle. So now I want to move on a little bit to think about systems and what do we do in terms of making decisions. So this is a framework that, again, some of you may be very familiar with. It's been around a long time. It's been attributed to several different people. It's presented in different ways. But really, when you think of it, it is. So when there is clear agreement about things and when there's a good degree of certainty, everything is very clear and very straightforward. Okay? And then when it gets, as you go away from the degree of agreement and degree of certainty, things become from clear to complicated to complex to chaotic. So what do I mean by that? So forget about patience for a minute. Something that's very clear is like switching on a switch, okay? You come into the room, although these days switches of course get more complicated, but you come into a room, you switch, you expect the light to go on. That's it. Clear. Nobody disagrees about that, and you're pretty certain it will happen unless it blows, but otherwise it will happen. Now, think about assembling a flat, what do you call it, a flat pack bed. I remember trying to assemble this once. It's complicated, isn't it? So there's a set of instructions. It is complicated. But actually, if you follow it through, it will happen. So it's not simple, but it is quite certain. And then think about the world that we live in and how complex it is and how uncertain it is. And I know you will hate me for saying this, but that word Brexit just makes everything complex. In fact, actually it makes it chaotic for us, but it is complex. So the certainty and agreement is kind of moving away from each other. And then think of the world of chaos. And however bad we think our world might be, think of areas of conflict, think of areas where actually it is total chaos. So that's the kind of spectrum we want to think about. Now, if we think of somebody like Mrs. Doyle, so she had, at least even though she had to come to terms with her husband's diagnosis of dementia, when her daughter Anne was well, there was a reasonable, clear agreement about how they would manage things, how they would share that caring load. And then it got a bit more complicated when Anne got ill. But still, she was going through the process of waiting for a diagnosis and things were moving. And now it's really very complex, and she probably feels it's chaotic because actually they're still waiting to find out what might happen. She has no idea how long the prognosis is. She's no idea what the treatment options might be, and so on and so forth. So I think this is an interesting framework because it just helps you to kind of think, if you're faced with a tricky, challenging decision, where does it fit? Where might this fit? Is this complicated? I think the bits that's often difficult is it complicated or is it complex? And the reason that's important is because your approach will be different. If it's clear, there is only one way to do things, and you produce best practice guidelines. Okay, there is only one way to do it. So think about somebody who has opioid responsive pain. You're going to start them on opioids. It is absolutely clear you're going to start them on the lowest possible dose. Yep, nobody has any disagreement about that. And that you titrate upwards. It's very straightforward. And then they have slightly more complicated pain. And they have both opioid responsive pain, but they also have bone pain. Well, it's a little bit more complicated, and they also have some other renal failure, so you then have to think about what drugs you're going to use. It's a bit more complicated, but it's still manageable, isn't it? We still have a reasonable amount of good practice around that. We know about good practice. And then they've got neuropathic pain, and then they've got a chaotic household at home, and everything's falling apart, and it starts getting more complex. And then your judgment really comes in, and then you're testing things, and you're pulling back, and you're testing again, and so on. So the important thing is we don't try to apply the wrong solution to the wrong type of problem. So if it's complex, we need to recognize it's complex, and we need to move with that, and we need to know that there is no one right answer. And again, the situation we'll describe very often in my setup on NHS England is that there is often a tendency on policymakers' view is that there is a simple solution for complex problems, and that's where you fall apart, is because you think that one solution will work across the country, and it won't. So it's really important that we recognize whereabouts that problem lies. And then I want to move on to thinking a little bit about this whole idea of old power, new power, old sort of dominant approach to leadership and new approach to leadership. Is this something that's familiar to people in this room? It's been around a little bit, but it's really kind of talking about, so the old power is what I've got here, where the power comes through hierarchy, okay? There is a mission, there is a set of values, there is clarity about that, there is a traditional way of doing things, and the leadership is top-down, and that it is much more transactional, and you get on with things, and things are much more organized. That is the dominant approach. Okay? Now, that's what's called old power. New power is that emerging direction there on the right, where actually the power comes through connections that you make. The power comes through having a shared purpose that you build together, you hold on together, that you make sense with each other through that emotional connection. And it's driven from upwards, and it's absolutely based on relationships rather than transaction. Now, I think very often when people think about new power, old power, there is a tendency to think, that was old, this is new, we no longer need this, and so on. But actually we need both, and we need both in different situations. And that became really clear to me when I was discussing this recently with a friend who used to work in the armed forces. And so I was describing this to him, and he said, you know what, this is exactly what happens to us. So the dominant approach is the strategic approach. This is when, if you like, the army says, we're going to take that area, okay? That is the sort of the geography that we're going to take. And that's a dominant approach. They can set that from back in headquarters. But actually, when you're on the ground and you're in small groups and you're fighting or doing whatever you're doing to try and take that piece of ground, what you need is the new approach, because the reason people really battle what they battle is not because of Sir back in headquarters, but because of their mates around them, because of the relationship they've built. And the best decisions are made because of that relationship. So if you have a dysfunctional unit on the ground, you can forget it. So that's the kind of relationship. Now, if we come back and think about our world, we actually need a balance of both of those worlds in order to make things to work. And if you think of the patients you look after, that's what you do, don't you? Especially when you work across organizational boundaries. It's always about the relationships. So the same authors then talked about what is it that allows that transformational change to take place. And they talked about some enablers. And I think the first four are relatively straightforward. So they need people, we all need people in our organizations who question the norm, who rock the boat, but who stay in the boat. So these are not the ones who are totally dysfunctional, who throw in lob in some stuff and then walk away from it. They're people who are really prepared to work with you to improve things, who challenge but improve. The one leading from the edge, so you often try out things at the edge before you move it into the center. And I always think this is such a great example. The hospice is such a great example of that. Because when hospices started, they were on the edge, they were different, they were outside of mainstream healthcare. Look how centered they have become now. And yet the innovations still take place at the edges, doesn't it? And then you move it in. Constantly, there is that movement. And it talks about an enabler being around changing conversations and mindsets, because it's actually in the conversation and changing the mindsets that you actually influence people. So my role as National Clinical Director is a funny term, because the one thing I cannot do in England is direct anybody to do anything. In fact, it's the one sure way that they won't do it, because our new Health and Social Care Act, I say new, in 2013, meant that everything is locally commissioned. So from the center, all I can do is say, this is really good practice. Look how they're doing it over there. This is really why you need to do it. This is about persuasion. But if I say, you must do it, they'll just say, forget it. And legally, they would be right. So that's the kind of thing I think we've got to think about. And then they talk about the curators of knowledge being, again, sort of one of the enablers, about how do you actually mine the information that we have. Research is important for developing new knowledge, for pushing forward the boundaries, for finding out about more new ways of doing things, new ways of being more effective. But we need to actually curate that. Otherwise, it just sits as yet one more paper that nobody remembers what to do about, other than the authors. And then the last one, I think, is probably the hardest one, certainly personally, I find. Building bridges to connect the disconnected. Is so nice to talk to like-minded colleagues. It is so lovely to be here, because I know you all share what I believe in. But actually, if I had to sit here and talk to people who are totally unconvinced about the value of palliative care, that's really valuable. They might walk out, but that's still really valuable. So it's really important that we are able to reach out and reach the disconnected. The last kind of concept, so I've told you about the triangle around simple, complex, clear, complex, complicated. Yeah, so you've got that one. I've told you a bit around the old power, new power, and this is the last of the kind of concepts I want to talk to you about today. So this is talking about when you've got leadership for complex, challenging times, you need to pay attention to all three areas. Okay, so the area of public value. How can you establish the value of what you're trying to do? Of any new experiences, any new activity, how can you establish that value as being a public value? And what is our role as leaders in promoting that? Okay? Do we believe it is of public value? And then what about legitimacy and support? What do we need? What kind of support do we need to be given and to give in order to give whatever it is we're trying to do, whatever we're trying to change, that legitimacy? How do we provide that support? And then how do we make sure that there is capability amongst the people we need to do things, to do this new activity? How do we make sure there is operational capability? That seems really abstract, doesn't it? It is. I'm going to apply this to two situations in particular that I've had the pleasure, the challenge of having to manage in England. So the first one is back in 2013, about 3 months. 3 months seems to be a really interesting period for my career. 3 months after I took up post as National Clinical Director, there was the independent review of the Liverpool Care Pathway was published. So for people who don't know the Liverpool Care Pathway, though I can't really believe that, it was an approach to looking after people in their last 2 to 3 days of life. But it was a very clear approach. It was very much based on the principles of palliative care, but it then became codified, and then it became standardized, and then it became thoughtlessly applied in some places. So that was the problem. But anyway, in 2013, in fact, in 2012, this independent review was commissioned. It published in 2013, 3 months after I took up post, as I said, with a completely new healthcare system in England with new legal framework, which meant that nobody quite knew what we could do and what we couldn't do, including the ministers themselves. So this was quite a tricky time to try and manage something quite as explosive as that. And the recommendation for the review was that the Liverpool Care Pathway had to be phased out within 12 months. So the clock started ticking at that point. So if you think then what we did was I didn't know whether I was supposed to do this or not, but I thought I wasn't going to do this on my own. So I went to the recommendations, and various organizations were pinged to do certain recommendations. So we kind of gathered together, and eventually we became a set of 21 organizations. And we said, well, let's take this opportunity to improve care for dying people everywhere, in all settings, because the report was mainly about hospital, but let's do it everywhere. And what we did was actually we came together and said, what is it are we asking from the people who work in this area? What is it that we're asking from the providers? What is it that we're asking? Can we ask the same thing instead of asking slightly differently each organization? Let's try and do this together. And I think it was in the doing together that we gave each other this legitimacy and support. Because when we said, we came up with these priorities for care, nothing new in them, just 5 priorities for care. So they were simple, they were straightforward. But what we said was, this is what needs to be thought about when somebody is dying. The Royal Collegists then said, these are the standards that support this. CQC, who's our regulator, said that when we go in to inspect hospitals, this is what we will be asking for. So by actually giving the same message and asking the same thing, we gave each other legitimacy and support. I think the public value piece was probably there already, although I'm not sure that all members of the public necessarily saw it as a value, because this was done in the full glare of the media. But that was the public value piece. And then the capability piece, of course, is a little more tricky, because you need to make sure that all your staff had that capability to do it. And some of that is still going on. So for example, our General Medical Council has recently published their outcome for graduates that now incorporates end-of-life care within it. So some of this has a long tail, but actually quite a powerful tail. So it is that working together that enabled us, but it was a collective leadership. So although I convened them and I chaired them, actually I would have absolutely no power if they chose not to follow. So that was the kind of important thing, was that working together. Now that was actually, we then discovered we had an appetite for working together, and that by working together, it was quite fun really, and we could make things happen. So most of us stayed together after that, because during the course of 2013, 2014, all these other reports came out. The House of Commons had a Health Select Committee looking at it. There was the Ombudsman had another report came out. Some of these reports had been in gestation for some time, but for some reason they all came out in 2013-14. So it was a pretty explosive time for us. But actually it made us all come together and say, okay, now how are we going to address this? Because this is not just about the last 2 or 3 days of life. How do we improve palliative and end-of-life care across the board. How can we use this opportunity to do good together? And that's what we did. So we came up with, we looked at all the reports, we curated the reports, so we didn't try to do new things. We just looked at all those recommendations that were in all those reports and many more besides. There were hundreds of recommendations, all kind of saying very similar things. And so what they did was we produced these 6 ambitions collectively. A few other people joined us, so we ended up with 27 organizations. And this national partnership, so this was published in 2015. 4 years on, this partnership is still together, and we now have 33 members. So we've now got British Lung Foundation, Age UK, British Geriatric Society joining us. It's got wider. And what we've done is, again, if you look at these 3 areas, the public value was now, these are the 6 ambitions. These are now not just clinical or clinical and social care, but these are societal right across the board. These are things that everybody felt they could sign up to. We gave each other, again, legitimacy and support. And by staying together, we've continued to do that. I think we're now coming to a point where we've got to relook and say, what does the national partnership mean? What do we mean to each other? What can we do together? And then the capability is a piece that continues. So Health Education England is continuing that work, and they've produced some generic guidance. The paramedics have got involved, and they've got end-of-life care guidance now in their curriculum, and so on. So it's about the power of working together. So in my last couple of slides, I want to talk about how we should think about facing this. I think we need leadership. We need leadership that is courageous. We need leadership that is inclusive. And we need leadership that is both transformational and, most importantly, that's generous spirited. So we don't try to claim the leadership for ourselves, but actually that we share that. We need to build resilience in our workforce, the ability to bounce back when you've had a setback, the ability to manage stress. And I think that that is probably more needed than ever, building that resilience. I'm not sure that we've got very good ways of doing that yet, but we've got to learn how to do that. This term I love, pride and joy in work. Again, I heard this from Don Berwick very recently, and I started looking it up. If you look on the Institute for Health Improvement website, there is a paper called Improving Joy at Work, which is actually a lovely, lovely paper. And there is actually an online course, which in my madness I've signed up for, which started yesterday, on actually how do you find and create joy at work? Because that is about believing that every member of your staff comes in trying to do a good job, wanting to do a good job. And how do you create the conditions that enables them to do that? I think it is about collaboration beyond boundaries, as always. I think I've already demonstrated that. And if you come back to Mrs. Doyle, think about it in relation to caring for Mrs. Doyle, to supporting her and her family. That actually all of these things are things that we use every day, isn't it? In the way we look after people. It takes leadership, it takes coordination, it takes some resilience on our part, but it's also about building resilience on their part so that she can actually manage with what is going to be a really difficult situation. It's about having that pride and joy in our work so that we're looking not only at what matters to Mrs. Doyle, but what matters to us as the people looking after her. And what are the things that get in the way of that? And how do we get rid of some of the things that get in the way? And how do we collaborate across agencies that we're used to? And I think above all, it is about acknowledging and accepting that life is messy. Those of you who were at the conference in Limerick 3 years ago will have seen this slide before. I make no apologies for that because life is still messy. And that in the middle of mess, you can see that there is some peer work going on here, there's some learning going on here, there's some rest going on here, there's curiosity, there's play, and actually all the good and normal things of life are part of the messiness of life. And as long as we acknowledge it, we accept it, and we work with it rather than trying to tidy it up, I think we can face any challenge in palliative and end-of-life care, whether it's at a clinical level or whether it's at a system level or within our teams. I think we can do it. Thank you.